Well, good afternoon, everybody. My name's Esther Youd. I'm a pathologist in Glasgow and I chair the Death Investigation Committee at the college. Welcome to today's webinar. The Death Investigation Committee is organising this series of autopsy webinars, and this is the programme coming up and with some of the past ones as well. You can book any of these webinars on the Royal College of Pathologists website. They're all available to book in advance from now. You have to book each one individually. And we hope to see you again at future webinars. There are also videos available from some of our past webinars. Again, they're available on the Royal College of Pathologists website, and we'll pop the links to those and to the next webinar in the chat for ease of reference. We're usually hosting a webinar once a month, but actually we've got two this month, and our second one is actually just next week on the Human Tissue Authority. So thank you for joining us today. We're going to be talking about post-mortem CT. The webinar will run for about an hour and will include a short presentation. We'll then have a short Q&A section, and if you want to ask a question, please use the Q&A function at the bottom of the screen. This webinar will be recorded, and so you can see that video in a short time on the Royal College of Pathologists website. You can self-accredit one CPD point for attending today's webinar. So I'm delighted to welcome Dr. Lizzie Webb, who's going to be leading this webinar along with colleagues. Lizzie Webb has been a consultant histopathologist and post-mortem active pathologist for 8 years, initially in Kettering General Hospital, and then she came back to Leicester Royal Infirmary. She's involved with undergraduate and postgraduate training and is the ST1 lead for histopathology trainees in the East Midlands South District. And I'm delighted that she and her team are going to be joining us to talk about their post-mortem CT service in Leicester. Thank you very much.
Well, thank you very much, Esther. And firstly, apologies, but I'm not sure where the video part of my computer has gone. I even cleared up the office today in preparation, but you'll have to have me in disguise. So yes, thank you very much. But I wouldn't be able to do this presentation without my colleagues, Dr. Claire Robinson, who was instrumental in setting up the PMCT service in Leicester, and also Dr. Parna Deshpande, Consultant Radiologist, and both of them will be participating in this presentation. So today, what we're going to be looking at is the history of CTPM practice in the UK, and specifically here in Leicestershire. Then we'll be looking at our practice that we have set up in Leicester, how we triage cases, how we get cases up to the radiology department, how the radiology department sort of runs out with reporting and consultations with ourselves, how we potentially find causes of death and then can release the body. And then we've got 5 case studies towards the end. But first of all, I'm going to hand over to Claire, who's going to take us through the history of PMCT.
Hi, hello everybody. So just very briefly, PMCT isn't a new thing. As you can see here, it's been around since sort of the early 80s. There's debate on who was the first person to do it, as there often is in these things. And there's been a lot of talk about PMCT across Europe. But it only became apparent some years ago that Japan has possibly got more experience and perhaps even started before people in Europe became established. But they're only publishing in Japanese journals. But they've very recently become a lot more vocal and are talking a lot more about what they've been doing, which is great. When you hear about PMCT, the group that is most well known is the Autopsy group, based in Bern, Switzerland, which was started by Richard Dernhofer and in association with Michael Tarley. And they're one of the most prolific research groups in this field, and have done an awful lot of research to get it started. And a lot of people have based their work on that. Next slide, please, Lizzie. So in Leicester, we started a little later. About 2001, we were doing our first scans, and these were mainly for forensic cases and trauma cases. The scanning was quite basic compared to what we achieved today. The image at the top of the skull you'll see is quite not the best image. It looks a little out of focus, and that's because it's just the technology at the time. It was a single slice scanner we were using. When comparing that to today's, we generally use a 160 slice, but we have access to a 320 slice scanner as well. So things have moved on, so imaging quality is much, much better. And we started doing research because I was working with 2 professors, and that built up to doing our first DVI incident in around 2006, which is, we think, one of the first times that PMCT was used in disaster victim identification. Next slide, thank you. So in Leicester, as I say, we've been doing a lot of research. So we started in around 2004, as I said, doing the trauma and the forensic work, and that's developed. And we quickly realised that while CT is very good at trauma, that if we were going to look to replace or think about replacing autopsies, we needed to look at angiography. So post-mortem CTA is post-mortem CT angiography. And we were able to publish some research that showed that we could do coronary angiography, which would help us to diagnose ischemic heart disease and coronary artery diseases, which has helped us to move our service forward to enable us in 2015 to open a service to replace some autopsies that we're going to explain to you how we did go about that in a non-suspicious death investigation. Now, unfortunately, this had to be a family-funded service because we were able to achieve local authority funding. But through negotiations in 2017, that was achieved. So now we operate a fully funded service which covers the CT scanning element as well as the autopsy and the pathology and mortuary services as well. And we haven't sat on our laurels, and we've continued to develop that. And particularly at the beginning of COVID in 2019, we doubled our capacity overnight virtually, and we continue to work at that speed at the moment. So I'll hand you back to Lizzie. Thank you.
Thanks, Claire. So post-mortem practice in Leicester, we're actually under three coroner's jurisdictions. So there's the city in the south, north and Rutland, and we also undertake parts of Lincolnshire work. And as Claire already sort of mentioned, pre-COVID, most of our post-mortems were traditional invasive post-mortem examinations with perhaps maybe 2 or 3 cases a day that were triaged for CTPM. But as COVID hit, this sort of put everything on the opposite side, and we ended up putting a lot more cases through, and as mentioned, capacity increased. So we then pretty much went over to nearly fully PMCT, and that's pretty much sort of continued now. And that's really helped because although back in COVID times we didn't have that many cases because of COVID, in 2021 we were having maybe 10 to 12 cases coming in per day, and obviously doing invasive postmortems on that it would be very tricky and not really possible. So CTPM scanning has really helped, and that's where we are at the moment. But of course, what do we need? We need a really good team, and it all starts with the mortuary team, the front of house, the anatomical pathology technicians. We have to use our portering system within the trust, and that can involve also people from radiology and our pathology teams. We're really dependent on the radiographers, consultant radiographers that actually help perform the scans in the radiology suite. And we are very much dependent on our consultant radiologists, where they access all the images and look at the histories, and they produce reports for us. Then there's our secretaries and all the coordinators that are involved, providing us with all the cases, the lists, the arrangements, and liaising with everybody. And then finally, there's us, the 6 histopathology consultants that help run the service here in Leicester. So how do we go about triaging these cases? Well, as with anything, histories arrive from the coroner's offices, and they get put onto a computer drive. And we also have the paperwork in the system in the mortuary when we're in there as well. And the most important things are obviously the coroner's front sheet, and that has the details of the patient and also the circumstances of death. We also require GP summary, which has significant past medical history and the drug history that the patient, the deceased, have been on. We also have hospital notes. So if they've recently been in hospital and have discharge summaries, we require that. Or, of course, if the patient has died in hospital, we'll ensure that we look at the notes before proceeding and getting a picture of what's been happening. Also, we get the coroner's paper. It's the extra information, really, and sometimes these are family concerns, or they could be family questions which they would like us to answer. And then again, with everything, we have ambulance notes and police reports where appropriate. And here, this is just an example of a coroner's front sheet, obviously blanked out images here of the actual patient details, but this is a North coroner. And this is a bit of a better history than sometimes we sometimes do get the died at home and then blank, then with all the extra information that comes in after that. But this one's a fairly good one. We've got a bit of details here with the past medical history as well. So what types of cases do we triage for PMCT? Well, most of the cases will be those that are sudden unexpected deaths in the community, and they will evidently be mostly the elderly and those with significant comorbidities. So we're looking really for cardiovascular causes, respiratory, sometimes abdominal, ischemic change, things like that. But of course, since sort of September, we have had a little bit of a decline because the medical examiner has come in across England and is now examining or looking at assessing the deaths in the community and scrutinising them. So whilst we had an initial drop in September, we're starting to see a gradual increase, and that could be also because of winter pressures as well. So we get the sudden unexpected death that we think might come up with a cause of death on PMCT, but also we look at hospital deaths, especially those where individuals may have come into accident emergency and haven't actually got to have any radiology assessment, or indeed they may have come in, had something maybe 2 or 3 weeks ago, and then we can, and they haven't had anything since, so then we can pop them through the scanner and see if anything has happened subsequent. Occasionally, we do put it through decomposing bodies or decomposed bodies, and it is a little bit dependent on the circumstances and the circumstances of their death and the level of decomposition, because we can use CTPM really to exclude sort of trauma if they've had a significant fall and things like that. Drug and alcohol deaths, again, are useful. We put those through the scanner, although we bear in mind that we'll be obviously having to take some toxicology, and we may have to go back and do a limited. But it also helps just to exclude any traumatic injuries, which would be a bit more tricky to do on a normal traditional post-mortem. Diabetics, again, often they will have a lot of natural disease, and we may well be taking toxicology in these cases anyway, but they often do help. What we don't scan hanging cases. Our coroner in this jurisdiction requires us to do an external examination. If there's something suspicious, then we stop, but if not, then they're happy with external kind of review and grant, plus or minus some toxicology. Multiple trauma, and that what I mean by that is sometimes we do have deaths where people have gone in front of a train, and then we have body parts. So really, it's more identifying the body parts rather than anything else. And as I've mentioned, some decomposing bodies, we actually do go straight in and perform an invasive post-mortem examination, just dependent on the level of decomposition. So what do we actually do? Well, as with anything, we're in the mortuary, we always do our identification checks. We do a full, thorough external examination to make sure there's no suspicious marks on external examination, and if there are, we stop. We also can take toxicology samples at this time. And dependent on the history, if there's a history of cough, fever, or breathlessness, we may well also be doing nasopharyngeal swabs for micro and virology. And having done the external, looked at the history, then we'll be thinking, are we going to put this case through for a CT scan? Is it going to be a plain or a one with angio, or are we going to go in for an invasive examination? So with external examinations, up here on the left-hand side, we have the normal sort of hypostasis that you get the lividity coming on the back of the back here and on the arms. And this was just a case I had earlier on in the year that was amyl nitrate poisoning, where you get this grey-purple discoloration. So we have to decide, if we decided that they're going to be for a PMCT, whether we're going to put them through for a plain scan or whether we're going to ask for an angiography scan. And this, again, is dependent on the history and particularly the age of the patients. Older individuals or people with more comorbidities, with ischemic heart disease, diabetes, previous stroke, etc., we're more likely to put them through for a plain scan. When an individual is a bit younger, so that's anybody really from 55 and under, we're most likely going to put them through for an angiography scan. And the reason why it's important is because we have to be aware, especially if they've got high numbers, if we put everybody through for an angio scan, we wouldn't get them all scanned in a very sort of timely manner. It usually takes, probably once into the radiography department, maybe 15 minutes to scan, whereas one with an angiography can take up to 45 minutes. So we just have to have that at the back of our head. So once we've decided whether it's going to be a CT plain, CT angio, the deceased body are transported to the radiology department. We have afternoon sessions that run. They are scanned by the radiography team, returned back to the mortuary, and then it is the radiology consultants will assess and review those images and produce for us a standardised report. These reports are then emailed to the CT team and to ourselves, and it's then that we look at this, and with the history, with the images, with the report, we have to decide, is there sufficient cause of death here that would fit, that would be happy with, or do we need to go in and do something a little bit more targeted? So just before I show you how the radiology report's structured, I'm going to pass you back to Claire because she's going to have a few details about the difference between plain and angiography. Over to you, Claire.
Thank you. So yes, so when we do a plain scan, we scan the whole body. If it was a forensic or trauma scan, we would scan from top of head, skin surface down to toes. But with these patients, if we can't fit them onto the legs of the table, then we don't worry about getting feet necessarily. So we will scan doing scout views first, which for anybody who's seen a clinical CT scan, it's exactly the same. We do quick 10-second scans of the whole body to enable us to plan how to do our detailed scans. And just to note, the image on the left of the chest, abdomen, pelvis scan, you'll see that the arms across the body. And this is so that we can get the arms into the field of view if at all possible. And sometimes we can't do that, but we try and get the arms in whenever we can. So next slide, please. So like a clinical scan, we will do axial slices through the whole body. So we choose to do a head and neck scan, a chest, abdomen and pelvis scan, and then scan the legs separately. And we find that's a better way to do it, because otherwise, if you scan from head to toe in one run, you end up with an awful lot of images, which can be quite difficult for some softwares to deal with. So we prefer to break them down and do separate scans. We also do another scan of the head and neck with the gantry angled, and this is because we can get some artifact. So thank you. So this is what artifact looks like. So the image on the left is an image of through the neck and the top of the shoulders, wearing, oh, we're jumping ahead one. Oh, thank you. And this is because this person was wearing quite a thick chain. Some of our patients come to us fully dressed, so this isn't unusual, and you get similar appearance if they have dental amalgam or hearing aids, anything like that. And we found that obviously you can see here that you can't really diagnose anything in the neck like this. But if we angle the gantry, as we call it, which radiographers will understand, just move the tube, move the machine, then you're able to throw off the artifact. So the same area being scanned, as you can see the image on the right, gives us a much clearer image, so that we're able to particularly to rule out C-spine fractures in our trauma patients. So next slide, please. Thank you. So as you've heard, we do angiography in quite a number of our patients. Just to make you aware, we do targeted coronary angiography only. So we just look at the coronary arteries, and I'm going to explain a bit more how we do that. But it's basically so that you can do a similar examination as you would do in an invasive autopsy to look for stenosis or atheroma or other pathologies. There is other technique, which is the virtopsy study do, and another group in Lausanne, which do whole body angiography, which is the image here. They're very pretty pictures. They're very nice, but the technique is quite expensive and quite time consuming. So we have done a study, we've been part of an international 10-center study, but for our population that we examine in the UK, then the target angiography we find more appropriate than the whole body technique. Okay, so next slide. So preparing our bodies, we use a Foley catheter. So because this technique was developed within the NHS, we have done everything so that it's quite a cost effective, shall we say. So Foley catheters are 30-40 pence. And as you can see, we make an incision above the clavicle, raise the carotid, put the catheter into that. So the idea is that the catheter will go down into the ascending aorta. We then inflate the balloon at the end of the catheter, and that occludes the ascending aorta, so that when we put contrast down the catheter, it will then go into the aortic root and fill the coronary vessels. As you can see here, the equipment that we use are all things that we'd find in the mortuary. So this preparation is done by the APTs in the mortuary prior to them coming to the scanner. And it's just a matter of logistics here that's the technique, the method that works best for us. But as well, it keeps our APTs involved in the system. And they really enjoy that. If you want to read more about the technique, as you can see here, the paper by Saunders et al. Explains our technique in more detail. Okay, next slide, please. So we have a set protocol. We choose to do 5 runs here. If you look at this, other places do 3, and some places will only do 1. There are different reasons why we do this, but we are a radiographer run service, so we don't have radiologists looking at the scans as we're scanning. So we do a one protocol fits all essentially, and so that if we see if the radiologist sees an artifact or a pathology or something they're unclear on in a vessel in one scan, they've got several other scans to have a look at it and either exclude a pathology or give it with some confidence that that is a true pathology. As you can see, we use 2 different types of contrast. A positive contrast, which is the same that we would use in clinical practice. So the same contrast that we inject into our live patients, we dilute it. And we also use a negative contrast, which is air, and I'll come on to those in a moment. You'll also see from this that we roll our patients into what we call our right decubitus position, so roll them onto the right-hand side. And if we can have next slide, please. We roll for 2 reasons. It's not uncommon for us, as you'll know, to have a bit of post-mortem clot in the ascending aorta. And this is the 2 images at the top. So the first image on the left is you'll see contrasts, the white of the contrast sitting on a fluid level in the ascending aorta, and the white line coming off to the right is obviously the left main LAD, and the circumflex is just, you can see that because you can only see that because it's so calcified. But the problem is this clot, and this clot is occluding the left main stem, so it's stopping the contrast going into it. So by rolling the patient, which is the image top right, you can see that the clot has now dropped into the non-coronary cusp. And so the ostia of the left main stem is now patent, so we're able to fill it with contrast as we want to. The other reason for rolling them is to help get gravity to give us a hand with filling the vessels as well. So the 3 images across the bottom, the first image on the left, you'll see that the contrast, the white contrast, has a big gas black bubble above it, which is air, which is stopping the contrast getting into the right coronary ostia, which is the little black bit heading up. So we find this quite often, and it's something that we don't mind, but it's why we give a second injection while they're lying on their back. And normally quite often you'll get some filling of the right coronary artery, but by turning them onto their right-hand side, which is the middle image at the bottom, you'll see that the right coronary artery is now heading downhill, so that you can use gravity to help us fill the right coronary artery. And the image on the right-hand side now, you can see now that the left main stem is now pointing upwards. So by using air on the 4th run, with the patient still on their right-hand side, we can use gravity to help us fill the left main stem, as well as gravity filling the right with the fluid contrast on the previous run. So we use the 2 different contrasts for 2 reasons again. So next slide, please. So the positive contrast shows up white on the CT scans, as you've seen, and it really helps us diagnose soft plaques. So you can see there's a filling defect. Yeah, that's it. So we can see that this vessel is patent because we've got contrast going past that area that isn't filled. So there is some stenosis there of some description or some atheroma, but we can look at that in various ways. But the second picture shows that there's complete occlusion of the vessel because the contrast just stops. And that was consistent on all 5 of those runs that we did. So we know for definite that was a complete occlusion of the LAD that you can see here. So next slide, please. So you've seen already that calcification shows up white on the CT scans. So if we put the white of the contrast against the white of the calcification, it can be quite difficult for us to work out whether a vessel has stenosis in it or the degree of that stenosis. And so you can see the image on the left, we've got contrast going through an area of calcification because you can see the black now of the air going through that area of white calcification. So we can see again that one is patent. And the image on the right, you can see the right coronary artery has got a pinpoint stenosis. which obviously we would struggle to see if we were only using the positive contrast. So that's the reason why we like to give the negative contrast as air and the positive contrast as the fluid contrast that we use clinically. Okay, next, I think it's back to you. There we go.
Thank you very much for that. So as I mentioned previously, after the radiographers have scanned, as Claire has just described, the radiologist will be reviewing the slides and we'll be getting a report back from it. And it's just a fairly standardised sort of report, pro forma, with the technique, the general findings, and then we have the general headings of musculoskeletal, central nervous system, chest, cardiovascular system, abdomen, pelvis, and we also have a summary, and sometimes we also have a conclusion with what the radiologist thinks as potential cause of death. So once this CT report is received, if there's any sort of questions that we have, we can email or contact the radiologist just to sort of clarify a few questions. And what we then do as a pathologist is we collate all that information together and make a decision as to whether we can contact the coroner and say, yes, we've got a significant cause of death here, and release the body on the balance of probability. Or do we actually need to go in here? We haven't got anything that's definite, and therefore let's go in and do an invasive examination. But often this will be a targeted approach because we've excluded perhaps there being a stroke in the head. So we might just be limiting this to the chest. And also, we'll be we're quite lucky in Leicester. We have a number of us colleagues that we discuss the cases with ourselves and with the radiology team to decide whether there is sufficient evidence for a cause of death. So in the case that I've just given here, the report, we had a 68-year-old male, I can read this history while I'm just sort of talking through it, who had a history of hypertension, diabetes, mellitus type 2 with various complications and previous DVT. And basically his car had broken down and he pushed his car off the road. So we've got this history of sort of exertion, and then he was on the footpath going to the top of the hill, and then he collapsed. So it sounds, even from that perspective, that he may well have had an ischemic event like a myocardial infarction. Well, from that CT scan that we had back, which we've just seen on the previous bits, slides, we've got cardiomegaly and left ventricular hypertrophy. Well, that would certainly fit with his history of hypertension. We've got peripheral systemic vascular disease, and we've got a significant coronary calcification score of 2,800. So anything above 400 is classed as severe calcification, which we sort of say is severe coronary artery disease. So based on those circumstances of death, his past medical history, the external, the CT scan, potential causes of death here will be possibly hypertensive, and diabetic heart disease with severe coronary artery atherosclerosis. So you might even want to say myocardial infarction, because there probably was clinically, but hypertensive and ischemic heart disease is another option here with diabetes in part 2. We're also very lucky in Leicester that Aparna heads up the REALM meetings, which are opportunities to discuss some of the interesting and challenging cases where we constantly learn and try to sort of improve and get better. And these are sort of run every sort of 6 to 8 weeks, I think. And to be getting better at recognising features that are seen in radiology, and then seeing what can be happening when we do invasive post-mortems. Things that have come up actually that are being really useful on CTs. Several times we've had, I had a male in this particular case who was in his 60s, was an alcoholic. There was a dubious history of whether he had drugs misuse. And he had, according to the information given to me, no history of cardiopulmonary resuscitation. However, the CTPM scan showed that there were some rib fractures, and they weren't the usual sort of anterior ones, sort of lateral and posterior. So there was this odd sort of pattern. So at that point, it was like, you need to get more information, suspend the post-mortem, and actually transfer the case over to the forensics teams. So sometimes radiologists are the first ones raising the possibility of possible third-party involvement or foul play. And another case was when I had an external, I did some toxicology and requested a CTPM. And whilst we were waiting for the results of the CTPM, the police had done some further investigations, and now there were some more suspicious circumstances. So case again suspended, went to the forensics team. But, because at the time there were no suspicious circumstances and the history provided to me, I could have gone in and done an invasive post-mortem examination, and then the forensics would have had to have then gone back and done a second post-mortem on what I had done. So sometimes the CTPM process allows us a little bit of time. Sometimes that's a bit useful. We can get a bit more information to us. So whilst I was putting this presentation together, I just thought I'd have a look at my own practice over the last year in 2023. And I undertook about 230 coroner's cases. And out of those, there were 210, or 91% of them were CTPMs, 4% were invasive, and 5% were externals plus toxicology. And out of those CTPMs, 52%, as you can see on this right-hand side, were plain or or angios, and only that, and provided a cause of death. 32% in the red one here were CTPMs with toxicology, and there was 16% that required extra information. So it was here we had CTPM plus a limited examination. The purple one here is CTPM limited plus histology. Then we've got limited examination and toxicology, and here the full works are limited histo and tox. And just for interest, I've looked at sort of the first 6 months of this year, and I'm probably going in on about maybe 19 to 20% of my CTPM cases. So we'll start off with some of the cases for discussion. So the first one was a 77-year-old female who had a history of osteoporosis, and she lived on Narrowboat, and she'd been walking down the towpath. She'd collapsed, a bit incoherent. She'd taken to hospital, and they noticed that she had initially a low blood pressure, had a funny feeling in her throat, but CT showed nothing. Tropes was mildly elevated, but then normalised, and she was managed as a syncopal episode, and she was discharged home. So she travelled to a friend's house, so she didn't have to be on the Narrowboat that evening. But unfortunately, in the early hours of the morning, she was found gasping for her breath, collapsed, had cardiopulmonary resuscitation defib, but unfortunately died. So here we have one of the CTPM results from her, and I don't know if Aparna wants to come in at all, but
yeah, sure. So basically with this CTPM, it's a plain scan, and what we can see, as Dr. Webb is showing us, there's this this area around the heart, which is the pericardium essentially. That's pericardial fluid, and what we're looking for is to see whether it's dense or not. So if it's a ruptured myocardial infarction causing the pericardial effusion, you will find that we have what we call a Rhine sign. And what that means is that there's dense blood going all the way around the heart, and that indicates that the heart was still beating when the rupture took place. On the other hand, if it's related to CPR, or if it's fluid which is developed after the patient has died, so usually it's in cases of CPR, you find that you have more of a fluid level, a more of a dependency. And over here you can see on the right side where the fluid is, it is less dense than what it is where the arrow is now. So there is a bit of heterogeneity to this case. So it's not quite convincing for what we call the Rhine sign, because you're not seeing that dense blood going all the way around the heart. You are having there is some fluid there on the right side which looks less dense, which is why we weren't able to confidently say that this could be due to a ruptured myocardial infarction.
Great, thanks, Aparna. And as we mentioned on the report that we got back, yes, there's hemopericardium, but we're not entirely sure if we can 100% say that it happened ante-mortem. So there's this element of doubt. So in that case, I ended up going in and performing a limited invasive post-mortem. And indeed, there was 400 grams of hemorrhage and clot in the pericardial sac, but I couldn't find any obvious ventricular rupture, and there was no coronary artery dissection. However, what I did find was that the aorta here was a little bit baggy, and there was a rupture site just here. We could see that basically the wall of the aorta was very easily sort of split apart. And here again this is the area here of where the perforation into the pericardium had happened. So we've got an element of a dissection that's been happening in this thoracic aorta. We can see a little bit again of the hemorrhage in here. The splitting of the media from the of the wall of the aorta, easily separating, and right down at the sort of within the descending part of the thoracic aorta, you can see there's some complicated plaques, and it was this area here that I think was probably that initial site of dissection where blood had gone through and then had separated through the wall and gone through in a retrograde manner. And I do wonder whether when she had that initial collapse on the towpath, perhaps that was the first part of the atherosclerotic plaque, having got the blood going into the wall, and then obviously overnight and in the early hours of the morning, that's when it then went through, ruptured, and into the pericardium. So in this case, I think the cause of death we put as hemopericardium, and you could have either said ruptured dissecting thoracic aorta and due to ruptured atheromatous plaque. This is an example, not in this case, is an ante-mortem example of a sort of a chronic dissection. Over here, we would have the lumen, we have the water intima, media, and then adventitia towards the end. But out here, but what we can see is we have here thrombus formation, so it's been splitting within the media, and we've got areas of organisation. So some people can survive. Let's move on to case 2. This is an 86-year-old female. She'd had several days of back pains and a bit of a chill. She hadn't wanted any fuss, and she hadn't seen her GP for the last several years. She didn't really have much of a past medical history. But in the afternoon, she was found dead by her husband on the living room floor, and cardiopulmonary resuscitation was commenced, but she died. On external examination, she was 32. Her BMI was 32 kilograms per metre squared. She had marks of medical intervention from the cardiopulmonary resuscitation, and marks of medical intervention. So from this, because she was 86, I thought, well, we'll try for a CT plain scan first of all, and because of the history of possible chills, let's just make sure she hasn't got anything going on, any bugs or viral. They were all negative as it happens. But this is what we had from our PMCT.
Yeah, so in this scan, you can see now that that dense blood is extending all the way around the heart. So we're not getting that low density fluid. This is hyperdense blood. So this is highly suspicious of having taken place ante-mortem, so suggestive of a ruptured myocardial infarction rather than CPR related.
Great, thanks, Aparna. And yep, the report was here, hemopericardium, and suggested an acute myocardial infarction. So in this case, given what the findings were, we put down a hemopericardium down to a ruptured left ventricle, probably for myocardial infarction, with the features of left ventricular hypertrophy and coronary artery atherosclerosis in 1D. But here's other options that you could potentially use as well. We put obesity in part 2 as a indirect contributing factor. This is an example of a post-mortem left ventricular rupture for some of those that you might not have seen it. Obviously not in this case because we had a CT scan, but when we used to do invasive post-mortems, this was always a nice sign to see, really. You can see here within the left ventricle wall, we've got a sort of a laceration that we can see here. Okay. And then on these images, we have the mid-ventricular wall slice. So up here we have the anterior left ventricle, lateral wall of the left ventricle, posterior wall of the left ventricle, interventricular septum, and then the right ventricle coming along here. And we can see the mottling of a myocardial infarction over here, and then coming through the transmural sort of rupture that's caused, had blood that was going and seeping through. Okay, so on to case 3. Here we had an 81-year-old male. He had a history of COPD, hypertension, and high cholesterolemia, and he'd been reporting breathlessness but he was also holding his stomach with some abdominal pain. He went to bed at lunchtime, felt a bit cold, wanted to go to bed, collapsed, and his wife called 111. So Aparna might come across to you again.
So we've got the images of the abdomen over here, and this is an interesting case because usually with post-mortem CT we see that the abnormalities are related to the heart rather than the abdomen. And what you can see over here is that there's extensive blood within the upper abdomen. It's like extending around the structure within the middle, which is the abdominal aorta, which looks enlarged and a bit deformed, and all around the aorta, there's a lot of hyperdense fluid. So that is suggestive of a ruptured abdominal aortic aneurysm with extensive retroperitoneal hemorrhage, which would fit with the cause of death in this case.
Thanks, Aparna. And yes, so whilst there was some moderate cardiomegaly and some left ventricular thickness, the main findings here was the hemoperitoneum. So we had enough evidence here without going in to put a cause of death as hemoperitoneum, secondary to a ruptured abdominal aortic aneurysm, and either in 1C or 2, you can put your hypertension and hypercholesterolemia as risk factors. This is just to show you what you might find if you had gone on into an invasive post-mortem examination instead of using a CTPM. On the right-hand side here, we have the abdominal aorta, which is a fairly normal one. This is the bifurcation to the right and to the left, common iliacs, and all these little ones coming off here, your vertebral arteries coming off. But you can clearly see that on the left-hand side, it is looking very abnormal. We have significant atherosclerotic complicated plaque formation. The aorta is enlarged, it's aneurysmal. We have this really big thrombus, but as you can see that it's a little bit adherent. It's got that matted appearance, and there's probably a rupture site coming out here, and there's some hemorrhage out here. So that's another example of a ruptured abdominal aortic aneurysm. Case 4, 60-year-old, died at home. She'd had a recent history of breast cancer, recently had surgery, and then she was now on some neoadjuvant chemotherapy. Because of this, I was thinking, a pulmonary embolism is probably high up, because she's had the cancer diagnosis, but also she's on chemotherapy medications. Took her leg circumferences on external, but they were pretty much the same. She was a little bit overweight, but not massively, and decided to put her through for an angio, hoping that we might come up with something and maybe see a PE.
Okay, so over here we've got the this is the image of the upper chest and axial view. We can see the pulmonary arteries both on the right and the left, but there's nothing specific to it. So the problem with a plain scan or even a PMCT in general is not very good at looking at pulmonary emboli. We tend to say that there is a suggestion of a massive PE as a cause of death if there is a collapsed left atrium, and if you see asymmetry of the legs suggesting a DVT, and then potentially if you see heterogeneity within the branch pulmonary artery, suggesting that they've got a lot of clot there. But obviously, remember, on PMCT, you're going to have post-mortem clot as well. So that can be challenging. So in this case, we weren't quite sure whether there was some abnormality to the right upper lobe pulmonary artery. But overall, looking at the clinical information, the fact that the patient had breast cancer and had chemotherapy, she was going to be at high risk for pulmonary embolism. So that was definitely something that needed to be excluded.
Thanks, Aparna. And we had the report that came back showing all those features, as mentioned. So based on that, because we didn't have anything convincing or definite, I went in and performed a limited post-mortem examination. And lo and behold, we found this is the pulmonary vasculature, one of the vessels. This is the lungs here, and we have a piece of adherent thrombus or clot, part of the DVT, or this is the PE really that's come from the DVT, and that is present here. It's got that sort of mottling appearance, and different to different to post-mortem, where it's more shiny and soft PM clot. And within the same case, out at the peripheries, if you squeeze the lung parenchyma, we have this sort of the toothpaste sign when you squeeze, and you can see little pulmonary thromboemboli over there. Now, whilst we didn't have any evidence of residual DVT in the calf, with the leg circumference being sort of both the same, it doesn't mean to say that it hasn't been there in the first place, that it hasn't popped off and all of it's now gone into the lungs to form these PEs. So what we ended up calling here was there was bilateral pulmonary thromboembolitis. It was in both sides, and put it down to her invasive ductal breast cancer with notice of that she was on chemotherapy. And finally, case 5, we had a 48-year-old female. He was an asthmatic, and she had been out partying during the day, had been taking rather a large quantity of alcohol, but also some drugs, including cocaine. When she went to bed, she became very warm. She had a pain between her shoulder blades. She collapsed and became unconscious, and despite CPR, she died. So thinking about the history, I was thinking pain between the shoulders, is that like an aortic dissection or something cardiac again? So because she was so young and everything, I thought this would be another case for a CT angio, and obviously you'd be taking toxicology as well. Now, on external examination, she was a little bit overweight. She was just within the obese range. She had marks of medical intervention and changes of cardiopulmonary resuscitation as well. And here, all we had were some mild left ventricular features of mild left ventricular hypertrophy and no significant stenosis on the coronary angiogram, and nothing else really to sort of mention going through anywhere else. So because of that, I thought we're going to have to go in and find out what's actually happened. And we've still got tox pending at this point. But on limited post-mortem examination, the pericardial sac was normal, but the heart was heavy. It was 410, certainly heavy for her. And there was a focus of critical soft plaque coronary artery disease. So that wouldn't have come up necessarily on a plane, but I had thought it might have come up on the angio that I've looked at. But this was the actual case here, and you can see that there's pinpoint narrowing here, and even on this lower section here, with the eye of faith, there may just be a tiny little bit of the lumen left, but otherwise it was soft plaque disease here. And then when I came to section of the heart, there was an area of pallor and mottling on the anterior ventrolateral wall of the left ventricle. And I noted that the left ventricular wall was increased in size, and there were some frothy secretions and things within the lungs, which would be going with pulmonary edema or part of terminal events. So I had done some histology just to confirm, really, because whilst I could see that critical coronary artery atheroma, it was very focal, but we did have evidence on histology of some contraction band necrosis, probably not that great on that particular slide, but also we had some of the box-shaped nuclei, which you see with left ventricular hypertrophy. The lungs basically showed some pulmonary edema and some basophilic bacterial colonies, but there was no vital reaction. But what was most interesting was that indeed she had been taking quite a lot of cocaine, and that level of cocaine would have been sufficient for acute cocaine toxicity. She also had the metabolites of cocaine, benzoglucoline, and choline, which is the metabolite mixed with alcohol, so that would also fit with the history. And we know that acute cocaine toxicity not only can cause hypothermia, which could explain why she was getting a bit hot, but it causes cardiac arrhythmias, vasospasm of blood vessels, and sudden death. So here I had focus of critical coronary artery atheroma, but also really positive cocaine. So there was no doubt that we had a myocardial infarction, and in this I put it as a combination of acute cocaine toxicity and her critical coronary artery atherosclerosis, and put her left ventricular hypertrophy in 2, saying that it could be down to undiagnosed hypertension, could be if she was a chronic alcohol or drugs misuse that could be causing the LVH, or indeed some of her obesity. But with anybody that is young, I'm just put in my reports that somebody that has significant coronary artery atherosclerosis, you would want to be checking any first-degree bloodline relatives, have a lipid profile test, and they can go there, get that done by their GP, just to make sure there's no hypercholesterolemia or familial hyperlipidemia. Okay, so thank you very much for listening, and hopefully we provided a bit of insight into our practices of post-mortem CT here in Leicester. And we've looked at a couple of case studies and see how we use that, linking it in and using CTPMs as a bit of an adjunct to helping us find a cause of death. And so thank you very much. And particular thanks to Claire and Aparna for assisting in today's presentation. Thank you very much for listening. And are there any questions?
Thank you very much, Lizzie, Aparna and Claire. That was an excellent run through of your service and your considerable expertise with dealing with postmortem CT. We've got quite a few questions, so I'm going to just jump straight in with them. But if you want to add questions, then please just do that in the Q&A section. So first of all, there's a question: who does the triaging to decide whether a CTPM is the way forward? Is it the pathologist or the medical examiner?
Right, so we have the medical examiner obviously in the hospital and out in the community, so they will put the case forward for a post-mortem, but it's actually up to us to decide what we're going to do.
The pathologist.
Yes, pathologist, yes, sorry, yeah.
So there's a big question that might be quite a big answer, but are there studies independently comparing CT versus invasive postmortem?
I might hand that over to Claire because I think she's nodding quite a bit.
Yes, there are several studies that do a direct comparison. So when we're in our research phase, we would always do, having received consent to do it from the family, we would do a PMCT scan in the evening. The patient would then be sent back to the mortuary. The autopsy would be done the next morning, completely blind to the findings of the CT scan. And then we came together later, depending on which project we were doing, and compared the two findings. So one of the bigger papers that we published was a 250 case study doing exactly that. And if anybody wants the references, we can provide them. And there are other people who as well, Oxford have done, for example, a very similar study. So yes, there are several papers published from the UK comparing autopsy and CT directly, yes.
And I think that sort of working together with a pathologist and a radiologist and learning from each other and sort of comparing notes is obviously a really important part of if you're going to be setting up a service, because although you guys have lots of experience, if somebody was setting up a brand new service, they would probably want to do that sort of thing and learn from cases as they go along. But I was really struck as well that you described your experience of learning from cases now, as you're still going on, you've had already 20 years of experience, and yet you're still learning and still comparing notes. And I think that's really good. So next question: in deaths under age 55, would you do a post-mortem CT, even if there's a possibility of things like hypertrophic cardiomyopathy?
Yes, I think there's an argument to say yes, you could, because you want to make sure that you could exclude strokes, subarachnoid hemorrhages, things like that. And then, you'd expect then, if you're thinking of a HOCM, that you're going to have to go in and do a limited, so particularly of the chest, and you're going to be doing a histology and everything. So I think it is a good way of limiting the invasive interventions that you're going to do to the body, because I have to say maybe I might have been a bit skeptical about this 10, 15 years ago. But at the end of the day, if this was my relative, I would like them to have the least invasive procedures as possible to find the cause of death.
Okay, so next question is about the postmortem interval. So does the postmortem interval affect the effectiveness of contrast? Does things like hypostasis affect how contrast works?
I don't think I might have to go with the Aparna on here. I mean, we do, I guess, in a level of decomposition. Early decomposition can cause some changes in the bodies, and sometimes, for example, the other week I had to go in because there was some potential air in the abdomen. They weren't sure if it was a perforation, but actually the person was going off slightly, and that would have all been part of decomposition changes. So there was radiologists, it's very different from ante-mortem to post-mortem radiology, and certainly I know that Aparna and Claire run the course specifically for the radiologist to know those nuances and the differences that you might see ante-mortem compared to post-mortem. But Aparna, you might want to add any more there.
Yes, no, I agree with what you say. So the contrast is not so much the issue; it's that level of decomposition which will create the challenge when we're interpreting the CT angiogram, for example, because there's so much of air everywhere that it can be difficult to really see where the vessels are and where because the contrast might go in, but you might have so much of air around, it can be technically challenging.
The next question is about the Gatston score, which you already answered during your presentation. So thank you for that question. So the next one then is about, again, it's a post-mortem versus ante-mortem question. So you talked about, Aparna, you particularly talked about the challenges with pulmonary embolism, looking at whether it's a true ante-mortem clot or a post-mortem clot. But do you have the same problem with the coronary arteries?
So it's with the coronary arteries, because we're doing it with a set protocol where we give contrast first and then we roll the patient into decubitus position and then give the air runs, like the images that Claire went through. If you've got a good quality coronary angiogram, then you should be able to shift post-mortem clot. And the ante-mortem thrombus would stay static. It would stay as a filling defect on all the runs. And that's how you know that is an actual plaque over there or a stenosis. Whereas if it's post-mortem, it will shift. The problem happens if you're having technical challenges with the post-mortem CT angio. For example, the balloon catheter, the position of the balloon catheter is quite important. It needs to be in the aortic root. If the balloon catheter ends up in the descending aorta for whatever reason, or there's some other challenge in putting the balloon catheter in, then you may not get the contrast and the air going down the coronary arteries properly. And it's in those cases where you end up not being able to differentiate between the two. And the patient may go on to having a limited autopsy. But if you've got a good quality scan, then you should be able to differentiate between the two, yes.
And I found it really fascinating when you were talking through, when Claire, you were talking through the different processes that you use to be able to get those good images. I had no idea, just receiving a report that just has that interpretation. But it's obviously very heroic efforts to move things around and get the best images, which is brilliant. Again, the next question has been answered. I think it was about are there cases where post-mortem CT is done, but then an invasive autopsy is needed. And so Lizzie has quite nicely outlined examples of those through the cases as well. There's a question about stroke. So is CTPM effective in diagnosing cortical infarcts?
When it comes to infarcts, in my experience, it's quite challenging. If it's an acute infarct, which has caused death, it can be really challenging. If we obviously would be able to pick up an established infarct, but that won't be the cause of death. But it's like even in the clinical scenario, when we do a CT head, patient presents with a stroke, it can in the early phase, it can be difficult to pick it up on a CT head, and the patient may need an MRI brain. So it's the same thing with the postmortem CT. And then if you add in decomposition into that and postmortem changes, picking up an acute stroke can be really challenging. I think I've picked it up once in the last 10 years, so as a cause of death.
And that doesn't surprise me at all, because we struggle even when we're looking at the brain in front of us, having done an invasive autopsy as well. So
yeah, but I guess it's really useful, isn't it, Aparna? Because sometimes we have the sub-Rx coming up beautifully and intracerebral images. So
if it's blood, it's lovely. So it's still fine. If it's an infarct, not so much.
More trouble.
But hemorrhage, PMCT is great for that. Yeah.
So next, there's a question about the coronary arteries in terms of the technique. So do you ever see rupture of the coronary arteries due to the injection pressure? What sort of injector do you use?
In my experience, we've not ruptured coronary arteries. And I can say with some confidence, because I did a PhD in one of my chapters on analysing the technique. A part of that was I actually had a pressure wire in the aortic root whilst we were injecting on a number of cases, and we didn't achieve above 40 millimeters of mercury. So our pressures are very, very low compared to the clinical work. So we don't do any damage to the deceased whilst we're doing our angiography technique. So we haven't caused any ruptures that we're aware of. And I'm sure the radiologists would have picked up on that had we done so. So I don't think we could do that. In Leicester, we use a clinical injector, so the same sort of injector that you use for patients. It does have to be a simple one. There are two types. The one, a more complicated one, we found we can't use locally. But if you speak to your radiographers, if you're interested, or if you want to come back to me with those sorts of questions, I'm happy to advise. But I can also say as well, you can hand inject. And there is a centre in the UK that does angiography just with using hand injections.
Okay. Next question. What's been the main driving force behind doing CTPMs? Is it less expensive than invasive PMs?
I would say it's probably more expensive. Because if you think about, I mean, from pathology point of view, you've got the deceased coming in, you've got the mortuary, they're having to stay in the mortuary, so you're having to pay for that. And then the invasive post-mortem examination, that's the standard sort of fee that you have across the country, or can vary a little bit. But CTPMs, it is involving a lot more, and I can't remember. I'm sure it's just maybe under £1,000 or something. Maybe Claire, can you?
Not that much.
Not that much. How much is it? You'll know it all.
The cost of as you're right. By introducing the radiographer and the radiologist time and everything else, there is an additional cost, and we're lucky that we've been able to sort that out. Nationally, the charge for a PMCT ranges from around £250 to £1,000. And we cost ours, that we cover our costs within the work within the NHS, and it very much depends on whether you're working in the NHS or not, and or whether you're having to pay the radiographers extra because they're doing it as an additional work. So the cost is quite complicated.
And we've got lots more questions, but we're out of time. So I'm just going to ask one final question, which is about the radiology capacity, really. So it's given that you're doing all of these scans, but you've also got clinical work to be doing on living patients. How do you manage the workload?
Oh, that's a good question. $1 million question, really. I think we've got a very big team here in Leicester. So there's about up to about 14 of us now who are reporting post-mortem CT. So there's usually 2 to 3 people every day reporting. So that kind of gives us a buffer. And we're scanning anywhere upwards of 7 scans per day. So we can divide the work amongst ourselves. The issue obviously becomes if there's leave and things like that. So to be honest, I think the demand is just growing. And even though we've increased the number of radiologists we're training, I think it's just the way post-mortem CT is going, we're going to find that we need more and more radiologists doing it. And as you say, we all have our subspecialties, we all have our clinical jobs. So it's kind of like finding the balance. But the way we've done it is that we just do a couple of hours each week. So but we're talking about 2 hours each week, reporting a few scans there, and so far we've managed with that. But I think our demand is definitely growing. The good thing with post-mortem CT is that you're scanning from head to toe, so it's like almost like a general scan. So anyone who reports general radiology, general cross-sectional imaging, should be able to do report a post-mortem CT, because all they really need to learn is what are the normal post-mortem CT findings. So it is something that radiologists find really interesting, because it's different from what they normally do in their day-to-day hectic practice. And it's almost like a bit of detective work, but at the same time, you're using the skills that you already have to help you do the report. So I think most of us, we all really, really enjoy it, and you see more and more people wanting to get involved. So it's good.
Yeah, from the scanning point of view, we're very lucky that our management saw this as a clinical service, essentially. And so they've brought it in scanning in hours. But that wasn't until 2017 when we started the full-time service. So up until that point, we were using the clinical scanners that weren't used out of hours. So all of our post-mortem scanning up until 2015, 2016, or in 2017 was done out of working hours. And I think that's the way for people to start. If you've got a scanner that's available for an hour or so a day, then you could actually just start doing a proof of concept study.
Yeah, I did a few at 5 o'clock in the morning with a friendly radiographer and radiologist. Well, thank you all. Thank you to all 3 of you for a fantastic webinar and for answering so many questions. And apologies to our attendees that we didn't manage to get through all of your questions. We hope you enjoyed the session, and we hope to see you for future webinars, well, the next one being in a week. Thank you very much, everybody.